Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through infectious disease pharmacology. We're going to start with antibiotics, move on from there to the other different medications such as antivirals, antifungals, antiprotozoals, etc. So let's go ahead and start with antibiotics, and we have a bunch of key concepts to get into before we go any further in infectious disease. Do keep in mind the antibiotic session will be the largest section of this lecture. So let's go ahead and get started with a few key terminology. Bacteriostatic means something that inhibits bacterial growth. So if I say a drug is bacteriostatic, that means it inhibits bacterial growth. Bactericidal kills bacteria. And you may see that on like Clorox wipes or other things, that bactericidal word. Examples of gram-positive, I don't know that you'd have to know this at the RN level. You probably already learned this in chemistry or microbiology. Staph aureus, streptococcus pneumonia, etc. Some gram-negative ones would be E. coli, H. influenza, Haemophilus influenza, Klebsiella, H. pylori, Helicobacter pylori, chlamydia. Those are examples of gram-negative. Again, gram-positive and gram-negative refer specifically to antibiotics. There are other types of pathogens out there. There's protozoal, there's fungi, there's viruses. Right now, we're talking about just antibiotics. However, before we go any further, I do want to clarify that one point. Antibiotic medication is only going to work against a bacterial infection, just like an antiviral medication is only going to work for a virus, and so on and so forth. There's no way that an antiviral medication is going to help a patient who has a bacterial infection, vice versa. And we'll talk more about this because this becomes why it's really important to tell a patient that has the flu why they don't need amoxicillin, because amoxicillin is for bacterial infections. Influenza is a viral infection. Moving on, let's go finish up our terminology. We have DOT, direct observation therapy. And this is where a medication is taken directly in front of the healthcare provider. We do this sometimes for communicable diseases, maybe tuberculosis, where we're concerned about compliance. We do this also in other areas such as mental health when a patient's under involuntary admission. Next, let's talk about antimicrobial stewardship. Antimicrobial stewardship is a global approach to address antibiotic resistance. So you may see those two terms used interchangeably, antimicrobial stewardship and antibiotic resistance. What is that? Antibiotic resistance has been recognized about 20 or 30 years ago as a global health emergency, and it's where we're using so much antibiotics that many of the pathogens out there, specifically bacterial pathogens, are becoming resistant to many of the antibiotics that we have. Because of that, over time, and we're talking not such distant future, our antibiotics will eventually be impotent against some bacteria that could catastrophically affect the human race. So antibiotic resistance is the issue, and antimicrobial stewardship is our efforts to rein in, so to speak, to get better control of our antibiotic usage to prevent progression of this situation of the development of antibiotic resistance. So a few key things you have to know. First of all, if we give a patient the overall goal here is to reduce the amount of antibiotic resistance, specifically the unnecessary, because we know statistically that a large percentage of antibiotic prescriptions and antibiotic doses taken are unnecessary. And every additional, especially unnecessary dose of antibiotics is making the situation worse in terms of the development of resistant pathogens. So what do we want to do about that? Number one is match the drug to the bug. That's a catchy terminology that was developed. And that means that we're supposed to be giving the correct medication to the correct infection. So we don't want to give a patient let's say, a UTI medication when they have pneumonia, things like that. Next, and that does fall more on the provider, but it's still something you should know about as a nursing student or a nurse. Next, we want to use narrow spectrum antibiotics whenever possible. Just like we talked about in previous lectures about steroids, that we'd much rather use a topical steroid or a inhaled steroid versus a steroid oral dose, because that'll have systemic effects on the whole body. Same thing here with antibiotics. I would rather use a targeted antibiotic, something that's specifically going to target, let's say, cellulitis, or let's say a UTI or pneumonia, rather than something that's going to kill off every bacterial pathogen in our body. When we do give broad spectrum antibiotics, and we'll talk more about that as we go through the different antibiotics, when we give a broad spectrum one, we are increasing that risk of developing a super infection, or I have seen some textbook write it as supra infection, just to give you a heads up on that. We also want to start with prevention, because that's always going to be the best thing to prevent a patient from getting sick, as opposed to dealing with it after they become sick. And vaccines is definitely a winner for that. And we're going to talk in depth about vaccines in a few minutes. Also, for prevention, as a nurse, always advocate for your patient. And if they're sick with an infectious disease, pneumonia or influenza or something like that, always try to get them a note to get them out of work or school so that they don't have to go around and infect others. Antibiotics, relatively broadly speaking, they do increase the risk of C. diff. It doesn't apply to all antibiotics. It certainly applies to the broad spectrum antibiotics, the ones that are very powerful. So those medications, we do want to limit the amount or educate the patient that this may cause them to develop C. diff. Also, and along the same lines of this, just like it can wipe out the good bacteria that keep C. diff under control in our gut, antibiotics can also wipe or change the vaginal flora, making the patient at risk of developing a vaginal yeast infection. That's very common. And if you do have those patients that tell you, oh, I just got prescribed an antibiotic, I'm also going to need something for a yeast infection, just let the provider know about that. I already mentioned this, the different types of pathogens, and we said there's really no crossover between a medication meant for one pathogen is only going to kill a pathogen within that class. We're talking bacteria, virus, fungi, protozoa, worms, and prions. Moving on, whenever you do have a patient that's prescribed an antibiotic, let's say it's for strep throat, then we want to also educate them that this is going to kill off the pathogen that's making you sick. This is not going to actually make you feel better. In order to actually feel better, you have to take something like Tylenol or Advil, ibuprofen, or acetaminophen. So do educate patients about that, reassure them that it's safe to take it with their prescription medication. Most PO antibiotic medications should be taken with food, and you do need to educate patients about that, and that's to prevent any GI adverse effects. There are going to be some exceptions to that we'll discuss. Very often, especially in the acute care setting, meaning an ER, before we give a patient antibiotic, the doctor is going to also order, or the nurse practitioner or the PA will order cultures, blood cultures. If you ever get an order to draw blood cultures, always do that before you start the patient on antibiotics, especially IV antibiotics, because once you start them on antibiotics, that messes up the results from our blood cultures. There is a test called a culture insensitivity. So let's back up a second. What is a blood culture test, or any culture, urine culture, stool culture, sputum culture? This is where we take a sample of the patient's bodily fluid, we send it off to the lab, and the lab grows it and see what grows in there. And they may end up with a nice little dish of E. coli or Klebsiella or whatever pathogen it is that's growing in that patient. So once we get the culture back, we know exactly what pathogen is growing in that patient. A culture insensitivity is a second step test. The second step is where the culture insensitivity, now we take that growth, that let's say Klebsiella, so we take that dish that has Klebsiella in it and we expose that Klebsiella to a bunch of different antibiotics. It could be vancomycin and tetracycline and fluoroquinolones, whatever it is. And then we see which of these medications is effective at eradicating, at killing off the bacterial infection that grew, in our example, Klebsiella. And once we have that result, now we know in that specific case, now we know 100% this patient who had Klebsiella, based on the culture insensitivity, if I give them whatever antibiotic, I'm just going to make one up here, ciprofloxacin. If I give that patient ciprofloxacin, I do know that it will kill that off, versus otherwise it was just best guess. Let's talk about that. We know that when you go to a doctor and you have an ear infection or strep throat or pneumonia, they're not doing any lab work to tell you what you have growing in you. They don't have a test that says you have H. pneumonia growing in your lungs. You have the diagnosis of pneumonia and you're prescribed, let's say, doxycycline is a common prescription. How do we know for sure that that medication is going to work? The answer is called empiric therapy. Empiric therapy is where we treat a patient based on statistical data. For example, we know that the vast majority of every strep throat is going to be killed off with amoxicillin. So based on that, the guidelines have been developed that say if you have a strep throat, you can treat the patient with amoxicillin. There's no need to do a culture insensitivity test. Same thing. If you have pneumonia, we'll say we know that the vast majority of all pneumonia will be killed off by either augmentin, which is amoxicillin with clavulanate, or doxycycline. So same thing. We're going to say either one of these, and there are some more nuances to it than that, but we're going to say that in the vast majority of all cases, you can just give the patient one of these two drugs, either augmentin or doxycycline, and it will take care of their pneumonia. Pneumonia is probably a bad example because there's different types of pneumonia. There's community-acquired pneumonia and hospital-acquired pneumonia that you'll get to when we get to respiratory, or if you've already been there. But let's just keep with what we're at. Empiric therapy is where we treat the patient based off statistical data, versus culture insensitivity is where we treat the patient where we know for a fact that our medication is going to kill the pathogen that's making that patient sick. Let's go ahead and start with the very first, the father of all antibiotics, and that is penicillin. So that would be amoxicillin, ampicillin, penicillin G, penicillin VK. There's a whole bunch of them. I didn't list them all. How do these work? These disrupt cell wall synthesis, so they inhibit bacterial cell wall synthesis. This is really very smart because we don't have, as humans, we don't have cell walls. We have semi-permeable membranes. So since this disrupts the cell wall, that's going to target bacteria. What do we use this for? Strep throat, ear infection, that's otitis media, syphilis, and a whole bunch of others. I wouldn't expect you to have to know that at the RN level. That's more at the provider level. Do keep in mind as we're going through the many different classes that we're going to learn about, and this is probably going to be the longest lecture out of all the bullet point nursing and pharmacology lectures. Penicillins are the first of the bacterial cell wall synthesis drugs, and I do have them grouped. The first bunch of drugs will all have the same mechanism of action. So let's move on. This group of drugs is also considered a beta-lactam. Penicillins are part of the beta-lactam antibiotics, and that's specifically the chemical formulation that it has. It has a beta-lactam structure to it, and so it has that group called beta-lactam. Again, I wouldn't expect you to have to know anything more than that at the RN level. The major adverse effect or side effect is that patients develop GI upset, and it can also cause prolonged bleeding time. Again, when you see that as a nurse, make sure you're assessing for bleeding or signs of bleeding in patients and educating them accordingly. I don't think you'd actually have to get into like ordering coag panels or things like that. If you don't know what that is, then you definitely don't have to. Moving on, this is the most common drug pharmacology or drug allergy in all of pharmacology. So we do want to be very alert for that. Patients that are allergic to penicillins also have a slight chance of being allergic to cephalosporins, which is the next drug class we have. I do want to clarify this for just a second. A patient who is allergic to penicillins has a slightly higher chance versus the rest of the population of also being allergic to cephalosporins. Slightly higher chance. In reality, most of the time we do consider it as a prescriber. I consider it safe that if a patient is allergic to a penicillin, we still give them a cephalosporin if they had a mild allergic reaction. If it was a rash or GI upset or whatever, then we go ahead and we say that it's still safe to give them cephalosporins. If they had a more severe reaction, if they had anything to do with airway or anaphylaxis for sure, then we're going to say we're not taking our chances, even though it's just a slightly higher risk of them being allergic to cephalosporins. We're going to say that they are allergic to cephalosporins, or that they should also not receive cephalosporins as well. And this is going to be something that you have to ask patients when you're giving them a cephalosporin and their chart says allergic to penicillin, to ask them about the severity of that allergy. So let's talk about beta-lactamase. Beta-lactamase is an enzyme that bacteria have that can inactivate our antibiotics. It's an enzyme that bacteria have that can inactivate our antibiotics. What does that mean? Think of it as a shield that some bacteria have. So bacteria go and they invade our body, and we send some amoxicillin to attack it, but they have these beta-lactamase shields that block our antibiotic, our amoxicillin, from killing off that bacteria. Pretty smart. We've in turn developed what's called beta-lactamase inhibitors. So beta-lactamase inhibitor would take down that shield. It would inhibit the beta-lactamase, the shield. Beta-lactamase inhibitors would go ahead and it would inactivate beta-lactamase so that our initial beta-lactam antibiotic, like penicillin, can now go ahead and have its effect. Hopefully that was relatively straightforward. I know it's confusing. Go ahead and listen to that again. So one more time, just a 2-second version. Beta-lactam antibiotics include penicillin. Some bacteria have a shield against that. It's called beta-lactamase. We have a drug that can take down that shield. It's called the beta-lactamase inhibitors. Now, beta-lactamase inhibitors will take down the bacteria's shield, but they won't actually fight off the infection. That's why if you're giving a beta-lactamase inhibitor, you still have to give it with an antibiotic. So most commonly, we'll give amoxicillin with clavulanate, and that's augmented. Or we have piperacillin tazobactam is another medication, and there are other examples as well. Finally, penicillins, not very commonly, but can cause a rash. And we have to investigate further, because if the patient developed a rash from amoxicillin, it doesn't necessarily mean that they're allergic, because if they got amoxicillin for a rash, then it could be that they didn't have something that needed an antibiotic. Maybe they had EBV, which is mono, Epstein-Barr virus. Epstein-Barr virus, which is a virus not treated with antibiotics. But if they got an antibiotic, because just FYI, mono presents with a sore throat and strep presents with a sore throat. So if the doctor messed up or didn't care or whatever and gave amoxicillin for EBV for mono, that combination does cause a rash. And now the patient may forever think that they're allergic to amoxicillin when really it was just what we call a mono rash. Moving on, we have our cephalosporins. This is a very big class of drugs. There's more than 20 drugs in this class. We have generations 1 through 6 right now of the different classes of cephalosporins. We have cefazolin and ceftriaxone, cefepime, cephaloxin. all different ones. Again, these have the same mechanism of action as the previous one and the next one for that matter. And these are used for a lot of different things. It's used for community-acquired pneumonia, for meningitis, for some STDs and more. The adverse effects, again, that same GI upset, so take it with food. It can also cause gallstones and kidney stones. This medication, we already talked about the issue with the allergies of penicillins. I'm not going to go over that again. This is also considered a beta-lactam antibiotics, and a bunch of these cephalosporins are going to be IV-IM, not PO. In fact, more of them are IV-IM versus PO. Also, cephalosporins can interact with alcohol, so do educate your patient to avoid alcohol while on these medications. Next, we have the carbapenems. These are only administered parenterally. These are not available PO. These are imipenem and meropenem. These work, again, by disturbing cell wall synthesis. But the bacteria's beta-lactamase will not affect it. It will still work. It doesn't need to be given with a beta-lactamase inhibitor. Next, and if I wasn't clear on that, we don't use the beta-lactamase inhibitor unless we suspect that the type of bacteria that invades that part of the body usually has that shield, that beta-lactamase. Otherwise, we just give the penicillin without a beta-lactamase inhibitor. Moving on, we have the glycopeptides. That's going to be vancomycin. Again, same mechanism of action. And this is used for some resistant infections such as MRSA. It's also used for C. diff. Vancomycin, very well known to cause nephrotoxicity and ototoxicity. Those are favorite test questions that I've seen in different test banks. So definitely make sure you commit that to memory. There is also something called red man syndrome. Red man syndrome is where when you give vancomycin via IV too quickly, and it does come both by IV and PO, but when you give it IV too quickly, a patient can develop red man syndrome where they get flushing and a rash and tachycardia, and it drops their blood pressure. The trick there is to slow it down or stop it completely and then restart it at a normal rate once the symptoms have resolved. Vancomycin is teratogenic, so it shouldn't be used in pregnancy unless there's no other option. The next drug we have is aztreonam. I have seen some textbook put this under the drug class monobactam. I didn't do that because that wasn't very common, but I just threw that in there in case your school does that. The mechanism of action here is disruption of cell wall synthesis. Again, the same thing we've been talking about. And we use this for severe infections. We also use it for C. diff. This is also available not as an antibiotic, but to be used for cystic fibrosis. And if it's used in that case, it's given via the inhaled route. And the most common side effect is diarrhea. I've seen some textbooks that completely left this medication off, so I wouldn't expect much on it at your school. Now we move on from bacterial cell wall synthesis to inhibiting protein synthesis. And that's going to be the mechanism of action for the next bunch of drugs. So we start with our tetracyclines. It's a broad class of drugs. This is considered a broad spectrum antibiotic, the tetracyclines. So we have tetracycline, doxycycline. These inhibit protein synthesis, which suppress the bacterial growth, which ultimately lead to bacterial death. Examples of what we use this for, we actually use this for acne, but a bunch of infections we use it for include chlamydia, community-acquired pneumonia, and more. I already mentioned doxycycline as in the guidelines for the treatment of community-acquired pneumonia. This does have some adverse effects, and some of these I've definitely seen in test banks. Make sure you know them, including discoloration of teeth, especially while they're still growing. So anyone who's not fully an adult yet, that would be a major issue. And for that reason, we often don't give it to children, especially under 12 years old for that reason. Also increased skin sensitivity, so photophobia or photosensitivity of the skin. And again, that GI effects. This one, however, should be taken on an empty stomach and very often should be taken with water. Dairy foods can interfere with this medication. I've seen that in some textbooks. I've seen it left off in others. So just take that with a grain of salt. And this one sometimes is actually encouraged to be taken with water in addition to being on an empty stomach. This medication is not recommended in pregnancy. I've seen some textbooks listed as teratogenic. I'm just going to put it as not recommended in pregnancy since others say just weigh the risk versus the benefit. Next, we have our macrolides. This is our go-to drug class when a patient's allergic to penicillins. And the most common one here is going to be a Z-Pak that I'm sure most of you have heard of. The drugs in this class are azithromycin, that's our Z-Pak, or erythromycin, clarithromycin. These work by inhibiting protein synthesis and suppressing bacterial growth. Again, same as the last one, same as the next one. The drugs we use this, or the diseases we use this for are chlamydia, pertussis, that's whooping cough, diphtheria. We can also use this for strep throat. We can use this for a whole bunch of different things. The adverse effects, again, the same GI upset. Make sure you take it with food. It can cause angioedema, which is facial swelling, so definitely be alert for that. It can cause hepatotoxicity, which means we're going to have to monitor AST, ALT. If we have a reason to. We don't just need that on every patient that's getting this, so do it with some common sense. And ototoxicity as well. So if a patient's having issues with hearing or something like that, then that might be cause for concern. And also, if a patient develops any hearing issue while on this, we would certainly stop it and reevaluate their hearing. Next, we have our oxazolidinoids. I'm not 100% sure I'm not pronouncing that correctly, but just go with it. Linazolid is the drug in this class, and this is a class that's used for resistant infections. Again, this is another one that inhibits protein synthesis. We use this for MRSA, which is methicillin-resistant Staph aureus. We use this for VRE, which is vancomycin-resistant enterococci. So these are 4 resistant infections. Next, we have our aminoglycosides. This is another broad class of drugs. This is considered a broad spectrum antibiotic. This is gentamicin and tobramycin and some others. Do keep in mind if you're used to using suffixes like LOL or all the beta blockers or PRILs or all the ACE inhibitors, you can't use that in infectious disease because we have 3 different drugs, for example, vancomycin, clarithromycin, and tobramycin, that all end in mycin, yet they all are 3 separate drug classes. So don't mess yourself up and get into that, at least not for infectious disease. Again, this is another one that inhibits protein synthesis. This is used for severe infections. I already said this is a broad spectrum class. The side effects here are tinnitus. So again, we might need to do some hearing stuff. If the patient is going to be on this and they already have underlying risk factors, again, that's not something in real life that we make a whole big deal out of, but certainly on tests, that's fair game. Dizziness and weakness would be other adverse effects. These drugs are mostly given parenterally, and they do have multiple black box warning for neurotoxicity, ototoxicity, nephrotoxicity, and that it can cause paralysis. Remember, each of those could be nursing school questions in terms of what drug needs a hearing test or what drug can cause CNS symptoms because of the neurotoxicity or what drug needs you to test BUN creatinine beforehand, things like that. Not that you really need to test it beforehand, but that you might need to. And aminoglycosides are not recommended in pregnancy. Again, that's going to be a risk versus benefit. Moving on, we have the fluoroquinolones. This is used to be a very popular class of drugs. It's come down a little bit, and I'll talk about that in a second. The drugs in this class are ciprofloxacin, moxifloxacin, levofloxacin, all the floxacins. These interfere with the bacterial DNA. So this is a different mechanism of action. These are used for a lot of your biological weapons, such as anthrax or the plague. It's also used for UTIs and hospital-acquired pneumonia and a whole bunch of other stuff. It has a very significant black box warning for tendinitis and tendon rupture. And it's because of that reason, because of the prevalence of that adverse effect, that we've actually backed away a lot from using this class. It's a broad spectrum antibiotic. It's very effective, but it has that major adverse effect that, unfortunately, because of its commonality of happening, and it's still not in most patients, but it's in enough that we've backed largely away from using that as a first-line agent. This medication also has a risk for those with myasthenia gravis due to the fact that it can cause muscle weakness. Moving on, we have our sulfonamides, and the drug over here is TMP-SMX. If you want to practice this a little bit, it's pronounced trimethoprim sulfomethoxazole. And this one works by inhibiting the synthesis of folate. If you already learned, or if you remember from your anatomy and physiology class about folate synthesis in relation to pregnancy, you'll know that this medication is absolutely teratogenic because we need folate synthesis in the early stage of the pregnancy, and this inhibits it. But this does it for the bacteria, which also kills off the bacteria. What do we use this for? Most commonly, we use this for UTIs, but we can also use it for other things as well. This does have adverse effects of causing lupus, rhabdomyolysis, and crystalluria. And like I said, this is teratogenic. Like I said, the most common time we use this is for a UTI. And speaking of UTIs, we have our go-to medication, which is the next one, nitrofurantoin. This is only used for a UTI. This damages the bacteria's DNA. This is the first-line option for UTI, although I have seen plenty of other places that have TMP-SMX, that's that drug we just discussed, or augmentin or fluoroquinolones listed as also equal first-line options for a UTI. However, nitrofurantoin is the least toxic, the least potent of all of these, so it's a very safe, gentle medication to kill off a UTI. Do keep in mind, if you're using this medication for a UTI, they have to have only a UTI, not that the infection already went up to the kidneys, which would be pyelonephritis, which would not be helped with this medication versus some of the other ones on that list would help for pyelonephritis as well. Also, just going to mention this here, and we mentioned this in another lecture of the nephrology lecture, the CAM for UTIs, the complementary alternative medication for UTIs is cranberry juice, but make sure you know that that is for UTI prevention only, not for treatment. Moving on, we have tuberculosis. Tuberculosis is the most prevalent bacterial infection in the planet, or on the planet, I should say. Roughly a quarter of the global population, almost 2 billion people, are infected or carriers for tuberculosis. We do have a test that we use for tuberculosis. It's called a PPD test. That's the skin test. Most of you are probably familiar with that as what might have been required at some point during your nursing school application. Let's talk about some drugs specifically for TB. While it is a bacterial pathogen, it does have its own medications for treatment. So the medication we're going to start with is rifampin, and this suppresses RNA synthesis. And this one is used for both treatment and prevention of TB. What does that mean? If a patient was infected with tuberculosis, this is part of the treatment, or if a patient was exposed to tuberculosis, this is part of the prophylactic treatment. Prophylactic meaning before the patient gets sick. It does have other off-label uses as well, and it is hepatotoxic. Big patient education point here. This can change the color of your bodily fluids, like your saliva or your urine, to a orangish reddish. So you may want to educate the patient before they completely have a meltdown about that. Next, we have isoniazid or INH, and this works by inhibiting synthesis of mycolic acid. Again, this is another TB-only agent. If a patient is diagnosed with TB, they're going to get 4 medications. They're going to get rifampin that we just learned, INH that we're learning about right now, plus 2 other antibiotics, pyrazidamide and ethambutol, that I'm not going to get into. Those are very uncommonly taught at the RN level. I see them in hardly any nursing school textbooks, other than the mention right here that it's used in combination with rifampin and INH for the treatment of active TB. Now, I want to clarify one more time. Patients who have active TB are treated with 4 medications, rifampin, INH, pyrazidamide, and ethambutol. Patients that were exposed to TB but are getting prophylactic treatment, meaning they are not yet symptomatic, they are only treated with rifampin and INH. Let's talk about INH. This is another hepatotoxic medication. It's also neurotoxic, and it could cause peripheral neuropathy. It has a black box warning for that hepatotoxicity. So that finishes up our section on antibiotics. I want to throw one more point in before we move on. Very commonly, you have patients that walk into the doctor and they're diagnosed with common cold or influenza or something like that, all viruses. When they're told they have a virus, very often patients are going to say, well, can I just get the antibiotic? I always feel better with a Z-Pak or amoxicillin, or it never goes away until I get whatever excuse they give. You have to understand that it's part of your job, because the provider is going to hopefully deny giving them that amoxicillin or that azithromycin, that Z-Pak that they want, because there's no need for it. They have a viral infection. A bacterial medication is going to do nothing for what they have going on. That being said, very often patients can be that way, and we have to make sure that you, as the RN, educate them that it really won't help. Even if you get that Z-Pak, it's psychological, it's not going to help, because otherwise, even if your provider is doing their job and refuses it because there's no reason in the world for it, and we've already said it's going to make the issue of antibiotic resistance worse, you still need to educate them on why they don't need that medication, so that they don't just walk down the block to the next urgent care, and someone will eventually just go ahead and give them their prescription to keep them happy. So do make sure and educate patients about that if you have a virus, an antibiotic is going to do nothing for you. Next, we're going to talk about vaccines. We have 4 or 5 different types of vaccines, depending how your textbook is going to break it up. We have the live attenuated, we have the inactivated, we have recombinant mRNA, which got very famous during COVID, and we have the toxoid. Almost every single vaccine is given via an injection. Some of them are given inhaled. That's more so for kids. We have, I put a chart over here on the different types of vaccines and exactly how they work and exactly which vaccines match up to which type. I wouldn't expect nursing school to really get into that, to know that COVID-19 is either the mRNA type, or to know that the inactivated vaccine is going to be what influenza is. I don't expect you to have to know most of these, but let's go through some things that I would expect you to know or have to know. Vaccine Adverse Event Reporting System, or VAERS, is a mandatory reporting that you have to do for any patient that has an adverse effect of a vaccine. So if they got a vaccine and 30 minutes later they develop a rash or something like that, you do have to, or maybe not a minor rash, but a major rash or peripheral or angioedema or something like that, you would have to report that. It is a mandatory reporting, just like child abuse, elder abuse, etc. Some vaccines require a booster. So what's the purpose of a vaccine? I guess I should back up and go into that. You probably learned this already, but I'll just give you the 2-second version. The purpose of a vaccine is to introduce your body to a pathogen without it making you sick. Because the traditional process is you're walking down the street, some infection gets into your body, it sets up shop, builds up enough of it that it makes you sick, and now your body's immune system will go to war with it, and that's why you get the fever, the chills, the whole everything, because of that war that's going on. The idea of a vaccine is that the pathogen is given to your body, but it's given in enough that your immune system fights it off, but not enough that you actually get sick, which is ideal. So that's the purpose of a vaccine. A booster is if, let's say, you're over time, I guess I have to back up a second. The end process of that war between the pathogen and your immune system is that memory B cells are created. And those memory B cells are there forever in most cases. And if that pathogen ever comes into your body again, a memory B cell is going to activate your immune system and is going to make sure that pathogen is destroyed before it can ever make you sick, which is great. And in theory, once I get a cold and my body fights it off, I should never get a cold again. And that's true, except there are 200 something different strains of the common cold, which is why you can get up to 200 something different types, different times you'll get the common cold. Once you've gotten all those different common colds, then yeah, you're pretty much immune. But the point is that memory B cells are created after every time you get sick. Ideally, the vaccine creates those memory B cells to fight off an infection before you ever get sick in the first place, and they serve to function that you'll never get sick from that again, because if it ever comes into your body, your immune system's going to immediately remember it and fight it off. Boosters are there that if those memory B cell levels drop over time, that your body maybe doesn't remember it as well, then we give you a booster to increase that amount of memory B cells to make sure that if that pathogen ever comes to you and tries to make you sick, that the body fully remembers that this is something to fight off immediately before it gets a chance to build up, set up shop, to build up an army and to make you sick. Many vaccines are part of a series, such as MMR and Hep B and many others. So those will require multiple doses in order to be fully effective. There is something called the vaccine immunization schedule. It's published by the CDC. It's updated on a regular basis. And I did put a link in there and just a screen grab of what that looks like. Depending where you're working, if you're working in any sort of primary care, adult or pediatric, certainly pediatric, you're probably going to have to be very familiar with that. Now let's go ahead and move on from bacteria, on from vaccines, and on to fungal medications. We have the azole antifungals as our next group of drugs, and these include fluconazole, miconazole, ketoconazole, and these medications work by interfering with specific fungal activities. You wouldn't have to know it more than that at the RN level. And these are used for candidiasis, which is a fungal infection, as well as some other fungal infections. Candidiasis, you should recognize oral candidiasis is known as thrush. The adverse effect of these medications, there is a whole bunch of them: cardiac and blood effects, Stevens-Johnson syndrome, or toxic epidermal necrolysis. Those are severe dermatological issues, as well as hepatotoxicity. Ketoconazole and miconazole are available in several formulas over the counter to be used topically for different infections such as jock itch and vaginal yeast infections. High dose ketoconazole is also used for Cushing's disease, which we're going to learn about in the endocrine lecture if you haven't already. And the azole antifungals systemically are not recommended in pregnancy. Next, we have the polyenes. This includes amphotericin. This drug works by causing cell membrane permeability and makes it very loose, and anything can get across, which makes the cells spill out their contents and the cells are killed off. This is used for severe systemic fungal infections. These do have some major adverse effects. It can cause nephrotoxicity and hematological issues. A lot of patients get an infusion reaction from this, including fever, chills, nausea, and headache. Anytime you see that, by the way, almost always that means we're going to pre-medicate a patient with something like ibuprofen or acetaminophen before we even start them on this medication. This does have a black box warning that it should only be used for severe systemic fungal infections. Next, we have nystatin, which is another antifungal that is typically given topically or via oral suspension. This is not an IV medication. And I'm not going to get into exactly what we use this for here. I did put one example up there that I've commonly seen in different nursing test banks, is that it's used for oral candidiasis, which is thrush. We also use it for candida that develops around the nipples in breastfeeding moms, things like that. Next, we move on from fungal infections to viral infections. Most viral infections do not require treatment, which is a good thing, because most viral infections are what? Are going to be your common cold, are going to be the flu, things like that we don't need treatment for. Viral infections are actually more common than bacterial infections, yet we're going to spend a very little amount of time talking about viral antivirals. Why? Because most viruses go away on their own. We have a joke in infectious disease that you take this medication, your infection will go away in 7 days, or you cannot take it and it'll go away in a week. It's the same thing. Next, drug class, we have antivirals. So the drugs over here are acyclovir, valcyclovir. The mechanism of action is that it suppresses synthesis of viral DNA. So these antivirals, don't get yourself confused. This is not for the common cold or for influenza. This is specifically for herpes, for varicella. These medications are taken orally. They do have adverse GI effects. And these are really only effective if taken within the first 72 hours of symptom onset. I want to clarify what that means. Patients that have, let's say, shingles, they get an outbreak of shingles. If within 72 hours they take this medication, it significantly improves the course of what they're about to experience with their shingles outbreak. If, let's say, they're at 5 days later and started 5 days ago and they come in looking for medication, it won't be as effective. However, if they've had multiple outbreaks, it started 5 days ago, but now yesterday they had another eruption, then absolutely, yes, we would give them, because it's 72 hours from the most recent outbreak of their flare-up of their shingles. Again, not again, but antivirals do not cure herpes or shingles. Those do not have a cure. They're with you for the rest of your life, but they do treat the symptoms. We do have another drug that's called an antiviral, and that is oseltamivir, which is Tamiflu. This is a prescription medication. It's given for influenza, just like the other ones. This only works within 48 hours of symptom onset. After that, it really doesn't do anything, which is why we really don't use this a whole lot. Studies show that if given in a perfect situation, it usually reduces the duration of your symptoms by about 24 hours. So you're not getting that massive benefit out of it. It's going to be a 6-day flu bout of the flu versus 7 days. So there's no massive benefit really in giving this. We don't do it a whole lot. Plus, you have to be within that 48 hours in order for this medication to be effective. I do want to go back to one thing, the shingles issue with the antivirals. We do very often, not very often, but many providers will give patients a extra dose pack to have for the next outbreak so that they can make sure they get in within that 72 hours that they start that medication. Next, we have under antivirals, we have our HIV medications. HIV, human immunodeficiency virus, is a viral infection, so we have our HIV medications. We're going to go through these medications. There's not a whole lot that's often tested on these medications. These are very detailed medications, and there's a whole lot that goes into it. If you ever work in an infectious disease clinic, this is about half of what they do. So this is definitely something you would have to know in that situation. But let's go through the different drug classes we have. Again, these are all under the viral pathogens. So we have the NRTIs, nucleoside reverse transcriptase inhibitors. The drug here is tenofovir or zidovudine. I don't know if I'm pronouncing either of those correctly. Hopefully I am. The mechanism of action is to suppress the synthesis of viral DNA. And these are used for HIV most commonly, but they're also used for HBV, which is hepatitis B virus. Black box warning for lactic acidosis and hepatotoxicity. The hepatotoxicity can come with steatosis. And zidovudine also has a black box warning for myopathy and bone marrow suppression. The adverse effects, there's a whole bunch of them because it's a pretty powerful medication, including Stevens-Johnson syndrome and toxic epidermal necrolysis. Those are severe dermatological issues, as well as hematologic, cardiac, and metabolic effects. Next, we have the NNRTIs. Before we go any further, if I didn't already mention this, all patients with HIV are going to be on multiple medications. They're never only going to be on one. They're usually going to be on 2 to 4 different drugs in order to treat their HIV. So the next medication we have here is efavirenz. And this is going to suppress the replication of viral DNA, similar to what the previous one did. And this is, again, used for HIV. This does have side effects of causing CNS symptoms, Stevens-Johnson syndrome or toxic epidermal necrolysis, as well as hepatotoxicity. This one is not recommended to be taken in pregnancy, but keep in mind there is going to be that risk versus benefit because if a patient doesn't take their HIV medication, they can develop resistant. Their HIV will become resistant to this medication in the future, potentially, and then they will be unable to be treated, period, for their HIV. And the NNRTIs, you do need to educate your patient to take it at bedtime and take it on an empty stomach. Next, we have our PIs, our protease inhibitors. Their drug here is ritonavir, and this medication works by preventing the HIV cells from maturing. And this is given to treat HIV. This does have side effects of high blood sugar, hyperglycemia, hyperlipidemia, bone loss, as well as some more. Next, we have the integrase strand transfer inhibitors, the ISTIs, and this includes like valtegravir and dolutegravir. And this one works by interfering with the integration of HIV into our DNA. This is obviously used for HIV, and it can cause insomnia, fatigue, and depression. So those are the 4 primary drug classes, and this is evolving. It's current as of today, but this is evolving as we continue our development of treatment for HIV. Now we're going to talk a little bit about HIV prevention. HIV prevention, also commonly referred to as PrEP. You may have seen the TV commercials to get PrEP. PrEP, P-R-E-P, is is prophylactic prior to getting sick. Okay, so it's prophylactic treatment before the patient actually gets sick. Pre-exposure prophylaxis, PrEP, pre-exposure prophylaxis. So we've talked about prophylaxis. If someone's exposed to TB, we said we put them on rifampin and INH. That's prophylactic. It's after they're exposed, but before they get sick. PrEP is pre-exposure. Before you're even exposed, you just know you're going to be exposed. And again, the common example is by having sex with someone that has or is at risk of having HIV or has HIV or other issues of transmission of HIV, such as using needles and things like that. So in those cases, we may recommend patients to take Truvada or Descovy. Those are the brand names. And the drugs here are tenofovir and emtricitabine. Tenofovir, you should recognize, as one of the NRTIs that we just learned about. And these drugs are part of PrEP, and these are taken a daily medication, and it dramatically lowers the risk of a patient contracting HIV by engaging in high risk activity that would ordinarily increase their risk of transmitting HIV. And again, the classic example is having sex with someone that has HIV. These will tremendously lower your risk. Obviously, this is used in combination with condoms and other methods of prevention. Tenofovir and tricitabine have a side effect of decreased bone mass and kidney injury. We do require that the patients get their kidney levels checked on a regular basis, either every 90 days or every 6 months while they're on this medication. We also require them to get routine HIV testing. Let me explain why. Because if the patient at some point actually becomes positive for HIV, then this preventative medication is no longer the right treatment, and we need to, as soon as possible, get them started on the full treatment medication, not just be on the preventative medication. It does have a black box warning that it can make HBV, hepatitis B virus, worse, and like we just said, that it can lead to medication resistance. If a patient is being treated for HIV with this, that would be a really bad thing because the patient will become resistant to these medications because it would only be a partial treatment, and a partial treatment leads to resistance. A few more notes about treating HIV. Most patients will take a combination of multiple medications. It is critically important for these patients to take their medications on time without missing a dose. They need to maintain it's something like 95 to 99% accuracy on their dose schedule. Missing some of these drugs, even more than 1% of all your scheduled doses, will cause you to become resistant to that medication, and that medication will never work again to treat your HIV. So it's really important. HIV patients are constantly going to be reassessed for their viral load. That's HIV RNA and their CD4 T cell count. Their viral load we want to be down. Their CD4 T cell count we want to be up. For nursing school students, that's a fair question of how would we reassess the effectiveness of HIV treatment. Terminology, you may see the term ART, that's antiretroviral therapy, refers to the treatment of HIV. ART therapy is lifelong. We don't have a cure for HIV, but this can manage it. Keep in mind, this is critically important for you as a nurse to know and to share. In today's day, when a patient is contracted with HIV, if they are fully compliant with their medications, they have the same life expectancy as someone else. Okay, it is a fully manageable disease. It's not a death sentence. It does not mean they're going to end up with AIDS. It is fully manageable if they follow the directions that they are given. This is on your job to make sure that they understand that, to counsel them, and to hopefully support them and guide them. Finally, healthcare workers may be required to take prophylactic treatment for HIV if they are exposed to it in the course of their work, which does happen. It's very uncommon. Even a needle stick from someone affected with HIV, I think, is still less than a 1 in 1,000 chance of contracting HIV, but just do keep that in mind that that may happen in your career depending on what setting you're working in. Next, we have our anthelmintics. This is our next type of pathogen. This is for worms, and the drugs over here are ivermectin or mebendazole. If you're getting bored of this lecture, please hang on. We're almost to the end of this. Next, we have our anti-malaria, and that treats worms, and actually it's just other types of worms. Anti-malarial is going to be the next one. Anti-malarial is going to be used, the mechanism of action is that it works against malaria. Malaria is a very prevalent disease. It's not very common in the US or in the developed world, but it is very common in other parts of the world. The drugs that we have are chloroquine and hydroxychloroquine. If you've already watched our musculoskeletal lecture, you've seen hydroxychloroquine in the past because it is also used as a rheumatoid arthritis medication. It's called a DMARD. You don't need to know the DMARD over here because over here we're talking about it as an anti-malarial agent. What do we use this for? We use it for both treatment and prevention. So this is the third time we mentioned prevention, because we mentioned prevention with TB prophylactic, we mentioned it with PrEP for HIV, and now we have a third one that before a patient travels to an area where malaria is common, we very often just put them on hydroxychloroquine 2 weeks beforehand or something like that before they even travel to that area. There's a whole list of adverse effects of this medication: cardiomyopathies, hypoglycemia, myopathy, mental health, retinal issues. We talked about the retinal issues in the musculoskeletal lecture, that it requires eye exams. Patient education is to avoid sun exposure. And this is the first-line treatment for malaria, and these are also the first-line preventative drug to take for malaria. Moving on from malaria, so far we just covered worms real quick, we covered malaria real quick, and now we're moving on to protozoal infections. So protozoal is another one of the types of infections, and this one works by impairing DNA function. This medication is used for trichomoniasis, which is a protozoal infection, and a few others. It does have a whole bunch of off-label uses. This drug, metronidazole, is the only drug that is used for two different types of pathogens because it's used for both bacterial pathogen and protozoal pathogen. It's the only one. Everything else I said stays in its lane. A viral drug only works for viruses. A fungal drug only works for fungals. This is the only one that has that advantage to it. The adverse effects of this is Stevens-Johnson syndrome and toxic epidermal necrolysis once again, as well as different blood disorders. So we may need to order a CBC or coags when giving a patient this medication. This is a very powerful medication when given IV. If you see a patient on this IV in the hospital, that's usually a pretty good indication that they got a severe infection. That being said, we use it very commonly in the outpatient setting for STDs like trichomoniasis. Next, this medication can absolutely not be taken with alcohol, so you have to educate the patient about that. Also, it does have a black box warning that has been shown to be carcinogenic in animals. Next, we have an anti-infective, and that's been bacitracin. You're probably familiar with that if you made it through childhood with any sort of cuts or scrapes. You might have had bacitracin put on your cut. How does it work? It inhibits bacterial cell wall synthesis. Back to the very beginning, that was what the penicillins do that we spoke about a half hour ago. The indications over here are prevention of bacterial infection. You apply it topically up to 3 times a day. And this drug is also available ophthalmic for the eyes as well as systemically. Next, we move on to the medications for scabies and lice. I know we're all itching already just saying the words. The drug class over here is going to be pediculicide, and the drugs here are permethrin and pyrethrin. These sell over the counter as Nix and Rid. Some of these are over the counter in some formulations, but they're also available by prescription. These medications kill lice and scabies. For scabies, you cover the entire body except the mucous membranes, and you leave it there for 8 to 14 hours. For lice, you wash the hair, the area of hair that is affected with lice. You apply the medication, you leave it there for 10 minutes, and then you pull it out. Hopefully by then it killed off all the lice, and then you just have to use that special comb to make sure you're getting every one of the nits that are left in the hairs. Finally, we have immunosuppressants. I don't know if every nursing school is going to cover this. It wasn't in every nursing textbook that I reviewed, but immunosuppressants are drugs like cyclophosphamide, cyclosporin. Steroids are immunosuppressive. Many of the monoclonal antibodies are immunosuppressive. What do you have to know about this? Just the real short version. These are all drugs that suppress the immune system. Sometimes that's a good thing. Sometimes that's a bad thing. It's a bad thing if that's a side effect, like steroids now makes you at more risk of developing an infection. It's a good thing if you just had a transplant and we don't want your body to reject the transplant, so we give you purposefully a drug to suppress your immune system. We also use to treat autoimmune diseases and some cancer. Depending which one we're talking about, because I'm not going into each of these, they have many, many different side effects that you may have. And any patient who's on an immunosuppressant, you should always educate them to immediately report a fever, stay away from anyone that's sick. If they're around someone that's sick, or if they're in the healthcare system, everyone around them should be wearing masks, etc. Hopefully you enjoyed this video. Please subscribe. If you have any questions, please reach out. Have a great day.